This discussion is going to focus on the neurological system, so we'll be looking at the anatomy and physiology of the neurological system and then getting into the pathologies that can occur within the neurological system. Okay, so looking at the anatomy and physiology, we're going to start with the cerebral cortex. So we'll go through the different areas, and then I have an illustration that I can see, and there's illustrations in your text that you could look at as well. So the cerebral cortex is responsible for motor function, cognition, memory, sensory perception, special senses are all responsibilities of the cerebral cortex. You have the basal ganglia, which is responsible for postural control and gross autonomic and fine movement. You have the diencephalon, which consists of the thalamus and the hypothalamus, and that is an area, it's a sensory relay area, and also has connection with the endocrine system. Emotional control comes from the diencephalon. You also have regulation of body temperature and fluid balance. You have the cerebellum, which is responsible for posture and movement and for fine motor movements. The midbrain brainstem complex, which consists of like the pons, the medulla oblongata. Here you have your involuntary functions, things like coughing, vomiting will all come from this area. And then as we move down further, you're into the spinal cord. And again, the spinal cord has various responsibilities, but some of them include the reflexes, including the stretch or the myotatic stretch reflex, withdrawal, cross extension, and grasp reflex. And here's a picture just kind of illustrating the various areas of the CNS. You can see the brain, the various parts of the brain, and then leading down into the spinal cord. So again, continuing on with the anatomy and physiology, we look at neurons. So neurons are the cells that kind of make up the nervous system, and we'll get to see a picture of a typical neuron on the slide when I bring it up. So neurons are composed of different parts. So you have the cell body, the dendrites, and the axons. The dendrites are responsible for receiving the input to the nerve cell body. And then the axons are responsible for carrying the information or the electrochemical impulses to other neurons. So you always think of dendrites delivering. I always think of it to remember this way: dendrites deliver the information, axons take it away. The other cells that kind of make up within the different functions of the nervous system, you have the astroglia, which are responsible for adhering to blood vessels to help form the blood-brain barrier, which we'll talk about later on. So the blood-brain barrier is a barrier membrane between the brain and the blood that circulates throughout the brain. You have the microglia, which are responsible for removing particles and microbes within the nervous system. And then you have the oligodendrocytes, which are responsible for forming the myelin sheath. So myelin is basically a covering that certain nerves possess that just help to speed up the information as it passes along the nerve. And collectively, all of these cells are referred to as glial cells. So here's a picture of a neuron, and again you could see the dendrites and the axon, and in the picture they're actually showing an axon that has a myelinated sheath. Again, the myelin just helps to pass information faster. So when you have nerves they're myelinated, they tend to pass information on faster than unmyelinated nerves. So further looking at the anatomy and physiology, we have the cerebrospinal fluid. The cerebrospinal fluid is a fluid that is kind of contained within the central nervous system. It helps to transport nutrients and chemical messengers throughout the CNS. It also acts as a protection and support for the brain, so it kind of makes it that the brain kind of sort of floats inside the skull instead of having it rest directly against the skull, so it kind of protects it from trauma to a certain degree. Then you have the meninges, which are basically it's a three connective tissue layer that again kind of supports the central nervous system. So you have the innermost layer, which is the pia mater, and that lies directly against the brain and spinal cord, and it helps to support the blood vessels and that kind of supply the nerves and the tissues in the area. You have then the arachnoid matter, which is basically where the cerebrospinal fluid floats, and it's kind of that middle layer between the two. And then you have the dura mater, which kind of isolates and protects the central nervous system from the internal and external environment, and that's basically the most superficial layer of the meninges. Then you have the blood-brain barrier. We kind of talked about the blood-brain barrier a little bit before in mentioning the cells. So the brain is obviously very vascular, but we obviously don't want every single thing that's going through the circulation to basically be absorbed in the brain, particularly when you look at a lot of medications. There are some medications that we obviously want to have work at the brain, and there's some that we don't. We don't want the brain absorbing all of that. So essentially what the blood-brain barrier does is it does just that. It provides a barrier to prevent certain substances from entering the brain that we obviously don't want to have enter. Here is a picture kind of showing you the meninges, and it's a pretty good picture showing the different layers relative particularly to the spinal cord. So you could kind of see, again, the pia mater, the arachnoid space or the arachnoid mater, and then the dura mater, and how those kind of line up and support that portion of the nervous system. So further looking at this, you have the different parts of the nervous system. So you have the somatic nervous system, and the somatic nervous system is basically the part of our nervous system where we have voluntary control of our body. So you're going to get input from both the afferent or sensory nerves, and then the output or from the efferent nerves are motor control. Okay, and again, the voluntary control of our body is going to be affected by both those sensory and motor nerves. Then we have the autonomic nervous system, where basically we have control of the involuntary things that our body does: heart rate, respiratory rate, digestion, all of the things that our body does involuntarily. And there's two branches of that. There's the sympathetic nervous system, and you have the parasympathetic nervous system. So the sympathetic nervous system, basically, again, we commonly think of the fight or flight response. We think of all the things that occurs with that: increased respiratory rate, increased heart rate. Basically, it's all the neuromotor response we want to, like, physical stress when our bodies have to respond to that. Whereas our parasympathetic part of our autonomic nervous system basically regulates the body at rest. So we think of like digestion, or again, the saying that kind of goes along. So we have fight or flight with the sympathetic nervous system. You have rest and digest with the parasympathetic nervous system. So if you would think, obviously, again, slowing heart rate, slowing respiratory rate, again, digestion, those things that we would want to have occurring at rest. Then we look at the cranial nerves. Again, so the cranial nerves are going to be up within our brainstem, and these are going to have certain functions that they're going to control. And typically, what we're going to do is that of these 12 cranial nerves, they originate from the base of the brainstem and exit from the base of the skull. Basically, we're going to want to look at function of them, particularly when we have a head injury or a disease that could possibly affect these nerves. From a sports medicine standpoint, we commonly do cranial nerve exams anytime we have a head injury, just to make sure that there wasn't any damage or bleeding that would be inhibiting the function of any of the nerves. We have our peripheral nerves, which are going to originate from the spinal nerves, and they're formed by the dorsal and ventral nerve roots that come off of the spinal cord. The dorsal roots are going to consist of sensory nerves, and the ventral roots are going to consist of our motor nerves coming out of the spinal cord. And then I'd already kind of talked about the myelin sheath. So the nerves are covered with myelin sheaths. Again, this is a structure that goes along the length of the nerve. It provides basically an insulating layer on the nerve, and it actually allows for the nerve impulse to travel and actually travel at a relatively faster rate of speed. So now obviously there could be disruption that could occur to nerves. For instance, there's different layers. Whenever a nerve gets damaged, there could be disruption of that nerve conduction. And there's different levels of that, which we'll discuss when we talk about nerve damage. Here's just a picture. It might be a little hard to read. You can kind of see what it's kind of getting at, but when you talk about the function of the sympathetic nervous system versus the parasympathetic nervous system, it just shows various functions throughout the body and what essentially it means. So you can take a quick look at that and kind of see what the different parts of the nervous system and kind of how they're influenced by each one of those portions. So next we have, so the structure and function, we have our cranial nerves. I'm just going to put all these up here. So again, anytime, from the standpoint of clinical evaluation, we like to do an evaluation of the cranial nerves, particularly when we're talking about head injuries, because it just kind of clears and makes sure that those function, because again, a head injury could impair function of the cranial nerves. And again, it could indicate that there's a more serious head injury. So again, I talk about this being common with concussion assessment. You have to be concerned that if you do have disruption or there seems to be a problem with function of the cranial nerves, that you would need further evaluation to make sure that there's not something beyond a concussion that would be. So here we have these all listed. Table 13.2 in your text goes through the function of the different cranial nerves. Again, you should note whether they are sensory, motor, or mixed. So some of them are purely sensory, some of them are purely motor, some of them are mixed. And see what they function, because what that actually tells you is when you're doing your assessment, what you would actually do to test the function of the nerve. So, again, just take a minute to kind of go through that table and add in those different functions from the different cranial nerves. So our other examination procedures, I kind of mentioned about the cranial nerves. Another thing you're going to want to do is test your deep tendon reflexes. So that will be another thing you look to do from an evaluation standpoint. And what you essentially want to note is whether they're increased, decreased, absent, or normal. And depending upon what how the deep tendon reflexes come about can tell you what type of injury, illness to the neurological system you have, and essentially you're basically going to be testing all these with your reflex hammer. You could take a look at the steps to follow, because there's some tricks, because sometimes doing reflex testing can be it can be a little hard sometimes trying to get reflexes on people even in normal healthy conditions. You're also going to want to note which reflexes you're testing. So C5 will be tested through the biceps, through the biceps reflex. C6, brachioradialis. C7 will be the triceps, and the patellar could be done. That will test L2 through L4, and the Achilles can be tested through S1. So that kind of gives you an overall look at those different reflexes. Again, you'll want to note whether increased, decreased, absent, or normal to kind of get an idea as far as what your pathology would be. Some other testing you would do, you have your long motor tracts or your cerebral cortex motor pathways. So that could be done with what's known as the Brzezinski sign. So basically with this, you can lay the patient supine, and you can just use a blunt object, just the end of the reflex hammer. You basically stroke the foot from the heel to the lateral border of the foot over to the ball of the foot to the great toe. What should basically cause this, what should essentially happen is the test should cause the toes to flex and point down. If it's positive, basically if the toes go up and the toes splay, it indicates what's known as an upper motor neuron lesion. So this is an injury involving motor information going from the brain to the spinal cord. So that's something that you would want to note. Clonus is another thing you could test for, which is another abnormal reflex, and you can either typically use the ankle for this. You can use the wrist as well. Most people use the ankle, and basically what you do is you take the ankle and you quickly move it into dorsiflexion. And what would essentially, again, under normal conditions, you shouldn't get any added movement. What would essentially happen is you would get essentially an involuntary oscillation of the foot. So say you took the individual's foot and you kind of put them quickly up into dorsiflexion a couple times. There shouldn't be any added movement. What would happen in a person with an upper motor neuron lesion, again, this test for the upper motor neuron lesions, they would kind of rapidly oscillate their foot on their own after you've done that. So it's sort of like added motion that would occur with the Clonus test. And again, these two tests, this and the Brzezinski sign, would be more upper motor neuron lesions, whereas like your reflexes look at the lower motor neurons. Some other things you could look at, so you could test meningeal irritation through the Kernig-Brzezinski test. So the Kernig-Brzezinski test is actually something that we test for with orthopedic conditions. When we're looking at low back pain, we look to see, if the sciatic nerve is irritated. But this can also give you some idea as to if there's just general meningeal irritation in somebody within the central nervous system. You could test sensation, general sensation and motor response. So you'd want to test your dermatomes and myotomes. That's something that you could also take a look at if you look in your textbook. Figures 13.3 and 13.4 go through the sensory distribution of both the peripheral nerves and the spinal nerve roots. So you could see both of them in there. Table 13.3 goes actually through your sensory motor and deep tendon reflexes. So you can actually look at, for instance, if you're testing the C1 nerve root, you could test where in the case of the C1 nerve root there really isn't a sensory per se. Some people do say C1 could also be tested with the top of the head. Your textbook does that with C2, but you could kind of see then the motor and the deep tendon reflex, if there is one for that particular nerve root. So that would be a good thing to review as well, to kind of get your from C1 all the way through S2, how to test for your sensory motor and your reflexes. For balance and coordination, a common test that we do as a part of our assessments for concussion is your Romberg's test, where basically you're testing the person's balance, having them on 2 feet, closing their eyes, making sure they can maintain their balance. We talked about cranial nerve function already. That kind of tests, information at the brain stem kind of coming out, those nerve roots entering or exiting the brain. Again, immediate referral should take place if by chance you do see any type of deficit that would necessitate immediate referral. Assessment of cognitive function, so you look at memory and attention. There's various ways that you can do this. There's various cognitive screening tests that you can do. Things like the serial 7s, having people count backwards by 7, or some people use the serial 3s. You could do retrograde, anterograde amnesia. So retrograde is an inability to remember events that occur before the head injury. Anterograde would be things that would you have trouble remembering things after. And there's also various standardized cognitive screening tools. There's the standardized assessment of concussion. And there's also various neuropsych tests. For instance, impact testing could do this as well. So there's various things you could do immediately on the field. And then there's things, again, like the neuropsych tests that you can do that are computer-based tests to see if an individual has normal brain function. So again, you have your individual your individual cognitive screening tests. Again, Those are things like I described, the serial 7, serial 3s, testing for retrograde, anterograde amnesia. Asking, for instance, your patients like a 3-word or a 5-object recall. That would be something that would test anterograde amnesia, because that would test their ability to remember things after the event. Retrograde amnesia would just be talking about, what led up to the event and things that they could remember within the day. Again, the standardized cognitive screening tools are just that. They're basically little standardized tests that basically go through, I had mentioned the standardized assessment of concussion, which is a very common one to use. Again, those sort of things just kind of give you objective data to be able to use and assess people with when you have concussions. And then you have the Neuropsyc tests, which again, these are usually, many times they're computerized. There are a couple of paper and pencil tests that you could still use. The impact test is probably one of the more popular ones that people use from a neuropsych perspective. And basically, these just, still measure a patient's cognitive impairment as far as their due to sport-related, what would happen, particularly due to a sport-related concussion. So here we have 2 different things that you could kind of note as well from the standpoint of from your inspection. So again, whenever you're inspecting a person, where there's a CNS issue taking place, you can note things. What we see here is what's called decorticate and decerebrate posturing. So in decorticate posturing, which is the picture at the top, you notice that the arms are rigidly flexed, the legs are an extension, and what that does is it indicates an interruption of neurological signals from the cerebral cortex, so from the higher areas of the brain. Then you have the decerebrate posturing, which is at the bottom, and that was where you have both the arms and legs are rigidly extended, and that indicates an interruption from the neural signals coming from the cerebellum. So here we're looking at the lower portions of the brain. So again, decorticate from the cerebral cortex, decerebrate from the cerebellum. So again, that would tell you that that's where you have some type of issue relating to the central nervous system. Some other important inspection points. So again, these could start to tell you about what could possibly be going on with the individual. For instance, if you have a skull fracture, you could have battle sign or raccoon sign. Both of them are basically bruising. In the case of battle sign, you have bruising back along the mastoid process. Raccoon sign is basically when you look around the eyelids and periorbital region. Nystagmus is any type of involuntary movement of the eyes. Again, that could also indicate injury to the central nervous system. And again, at the point you see anything like this, obviously at this point you're doing referral to for immediate medical evaluation. Obviously, you could suspect what's wrong with them, but at that point your assessment would pass on as they would be getting referred at the point of presenting with any of these. So looking at your signs and symptoms are common things that we tend to see within the neurological system. So syncope or coma, which is basically, again, your different degrees of loss of consciousness. Paresthesia, which would be like abnormal sensation in a body part. Abnormal motor control, coordination, or tone. Headache, vision, hearing, or anything related to the senses, and then changes in mental status. So these would be various things, again, related to, and again, depending upon the symptoms, you could be more, suspicious of, certain parts of the, the brain being affected and or kind of starting to go through a differential diagnosis in as far as what could be wrong with an individual. As far as pain patterns go, again, we're just going to kind of look at different parts. If we're looking at the dorsal spinal columns, again, they're responsible for light touch and proprioceptive impulse. If we look at the ventral spinal columns, those are going to be responsible for pain and temperature impulses as they kind of travel from the peripheral receptors and kind of enter the spinal cord. And then you have your peripheral nerves. Again, they're going to be responsible for various things. Again, peripheral nerves kind of transmit sensation, autonomic function, motor control to specific regions. So again, you can see, I had given that the illustration earlier. You know, figure 13.3 in your textbook shows kind of your sensory distribution of peripheral nerves. So you can kind of see where if you had damage to a sensory peripheral nerve, where that would be, what that would be associated with. So basically, when we're looking at like the possible pathologies, again, you could kind of look at the function of the different areas and kind of connect the signs and symptoms, what would be going on. So if you kind of know the functions of the different areas of the nervous system, you could kind of put in, like, you know, for instance, if a person would be having certain signs and symptoms, what's possibly getting affected. This is kind of summarized on this table. So, I mean, I'm just going to note the structures here. You could kind of see the possible pathologies, and you'll also kind of see this as we kind of go through the pathologies on the other parts of the discussion. So again, you look at the cerebrum, the basal ganglia, the midbrain, and the medulla. So basically kind of looking at the brainstem complex. This should actually be cerebellum. I accidentally put cerebrum twice. This should be your cerebellum. So this would be that would be another part you'd be looking at. And then the spinal cord, okay? You know, and there's pathologies that can possibly affect more than one area. For instance, multiple sclerosis could affect both the midbrain, medulla, and also the spinal cord. So that's something to kind of be mindful as well. Again, if you kind of note the signs and symptoms, you could kind of see and understand what functions that are basically getting interfered with at the nervous system based on the pathology.